My wife kept telling me, go get checked, go get checked, go get checked. And I said, no, I'm fine, I feel fine, I'm okay. Until I wasn't.
Until he wasn't. Thank goodness for his wife. A life-saving appointment, a stunning diagnosis, and finally answers to decades of heartache for Manuel Romo's family. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. The man you're about to meet has had his fair share of loss. After 3 of his family members died of a genetic condition that was undiagnosed, he's now sharing the diagnosis that saved his life with some gentle nudging from his wife. The simple act of sitting on the floor with his wife Cynthia and sorting through their children's toys is something Manuel Romo will never take for granted.
It's a blessing to have them around.
On this day, their sons are at school, and the couple has a rare afternoon of quiet time at home together. But the past several years have been anything but quiet. For Manuel, they've included multiple heart surgeries and a series of almost unimaginable losses. Beginning with his twin brother, Jesus, who died suddenly at the age of 18 in the middle of the school day.
He was just in front of the computer, and all of a sudden he just collapsed.
A few months later, Manuel's sister suddenly died. And then just a couple years after that, his mom. All 3 of the deaths were sudden and unexpected. After Manuel's twin brother, Jesus, died, Jesus was diagnosed with Marfan syndrome, a genetic disorder affecting the connective tissue in the body.
He had all of the physical traits. He was tall, skinny, long limbs, hypermobile.
While autopsies were not done on his sister or his mom, the family did learn that Jesus had died from an aortic dissection, which can be a danger when you have Marfan syndrome. So Manuel got tested and was also diagnosed with Marfan's, despite not having any of the outward physical signs that his twin had. Maybe because he had no symptoms, or maybe because he was a teenager grieving so much in such a short period of time. Manuel says he didn't go to the doctor again for another 10 years until he married Cynthia.
I kind of started to push him and be like, hey, it's been a decade. Probably a good idea for you to go get checked out.
My wife told me, you need to go get checked. You need to go get checked.
He relented. After a series of tests and scans at the University of Kansas Health System, which included genetic testing, Manuel was ultimately told he did not have Marfan syndrome after all, rather something called Loeys-Dietz syndrome. Loeys-Dietz is also a connective tissue disorder, but more aggressive than Marfan's, and it can also cause deadly heart issues. It's now what doctors suspect actually caused his twin brother's death, and they also think his sister and mom had it too, and that's what caused their deaths. Further scans with the cardiologist at the health system revealed Manuel had a large and growing aortic aneurysm. 2 months later, he underwent his first of many heart surgeries and procedures. The most extensive by cardiothoracic surgeon Dr. Todd Crawford, who just 4 months before this interview replaced Manuel's entire descending aorta.
So many of them.
These days, Manuel says he feels great, and he and Cynthia have a message for everyone watching.
Listen to your wife.
Well, that's pretty sage advice, Manuel. Listen to your wife. Everybody, did you get that? Where is Cynthia today?
She's at home watching the kids, getting them ready for school.
Your 2 little kids.
Yes.
We're so glad you're okay. And I'm sorry for all the loss that you went through before this diagnosis. We're thrilled that Manuel is here in the studio today. We also have his 2 surgeons. We have cardiothoracic surgeon Dr. Todd Crawford and Manuel's vascular surgeon Dr. Kara Hessel. They teamed up on the major surgery that Manuel had. They did that together. Also a note, speaking of surgeries, we will be sharing surgical images during this program. We'll give you a little alert before we get to those. Manuel, we thought you'd been through 4 surgeries, but then when Dr. Crawford sat down, he said, actually, it's been 7. You've been through a lot.
Yeah, I lost count of it.
When you lose count of open heart surgeries.
Well, not that.
That's a lot.
That is just 2, but all the minor ones, I thought it was just 5, but Turns out it's just more.
And is minor to Manuel something that would be considered major to anyone else if they just had one of those?
Absolutely.
So you've been through a ton. How are you feeling today?
I'm great. I'm feeling pretty good. I'm glad to be here.
Are you glad to be here?
Yes.
You kind of wish you were at home with the kids right now. I know this is stressful. We really appreciate you being here. How did you process learning that you did not have Marfan syndrome, but in fact you had this Loeys-Dietz syndrome?
Well, when I heard the news, I was relieved, but then I was shocked when they told me, you have Loeys-Dietz, like, what is that? I didn't know at the time what Loeys-Dietz was. So I was relieved, but then they told me, you have Loeys-Dietz is actually more aggressive than Marfan, so that was the shock.
The relief was a second until they corrected you and said, actually, this is
more aggressive.
Worse.
Yeah.
Dr. Crawford, does Loeys-Dietz have the same physical traits as Marfan's? Because, as Manuel was saying, he didn't show any of the traits of Marfan's that his brother had.
Yeah.
What are the physical traits of Loeys-Dietz?
Well, there is a lot of overlap, and it relates to the genetic component of this, which is the TGF-beta receptor signaling pathway. And so Marfan's also impacts that, but Loeys-Dietz really gets to the root of TGF-beta receptor signaling because it's a mutation in the receptor itself. And so that's why it's a more malignant phenotypic expression of this. So you do have overlap traits. Commonly you can see a bifid uvula, so the uvula of the palate actually has kind of two tongues rather than one. That's one of the classic findings.
In your throat, your uvula?
Yeah.
Okay, that's the drop in your throat when you say ah, so you have it two of them?
Exactly. Well, it's one that kind of
2 points to it.
has 2 points
Do
to
you
it.
have that?
Not that I know.
No, you would know if you had it. That's super interesting.
Yeah.
So from a vascular point of view, Dr. Hessel, what happens inside the arteries when you have Loeys-Dietz compared to Marfan's?
So there's similar processes, and it's all basically that we're all made up of connective tissue, and the pathways kind of lend strength or elasticity to our connective tissue. And when we have too much of either, then the arteries can either harden or they can actually be so elastic that they stretch too much. And in the case of these connective tissue disorders, we often see that they are able to stretch too much, and so then aneurysms form.
And how does that, Dr. Crawford, cause the aneurysm? What is happening during an aneurysm?
Yeah, so aneurysm just means pathologic growth of a blood vessel. And so, like Dr. Hessel alluded to, that imbalance of structural proteins leads to growth. But unlike other aortas, which can grow and tolerate it for a long time, the Loeys-Dietz aorta often tears much earlier, and the branch arteries also can tear.
So when you detected that there was an aneurysm on Manuel, the risk was his could have exploded much quicker. It forms and then bursts quicker than if you had Marfan syndrome?
That's exactly right. And so the guidelines for timing of intervention are actually different in patients like Manuel.
How many people can have this and not have any warning signs? How common is that?
It does run in families, but it can be a de novo mutation as well. And so unfortunately, probably for his mother and his brother.
What does de novo mean?
That means that the mutation can just happen out of nowhere. It doesn't have to necessarily be passed from one generation to the next.
And Carrie, excuse me, Dr. Hessel, we were talking about kids before this, so we were on a first name basis sort of, but Dr. Hessel, how many patients do you see that wind up having Loeys-Dietz? How common is that?
So it's a rare disorder. It's more rare than Marfan's is. The thing that we see most commonly is that it occurs at a younger age, and so it is unfortunately something where a lot of the time we'll see someone in the family has passed away from it, and that prompts genetic testing and other members of the family, and we're able to identify it and monitor sooner. As Dr. Crawford was saying, it's also something where since things tend to grow and the vessels tend to be more fragile, we do interventions much sooner. And we do different types of interventions in these cases than we do in people who have aneurysmal disease that's just related to high blood pressure or plaquing and things like that.
So Manuel, what was your reaction when you found out you had this aneurysm growing?
Well, I knew I was going to need surgery at some point because I was diagnosed with Marfan's when I was 15. But Well, I was expecting it. I just didn't know when. Yeah, that was my first thought.
What did Cynthia do? Did she say, aha, I was right?
I guess she was scared for me, even she gave me the told you so. Yeah.
Because it had been 10 years.
Yeah, 10 years without getting a checkup. I felt fine. That's why I didn't worry about it.
Do you think, looking back, there were any signs that you might have overlooked? Or you just felt fine?
I just felt fine, just like
Wow.
anybody regular, go to work, nothing.
Picking up your kids, being a dad, running around. As we've talked about, Manuel has had major surgeries, multiple major surgeries under both of your care. How many have you teamed up on, doctors?
Gosh, at least 4 or 5.
4.
4 of those.
Yeah.
Some minor and some major.
We have some images from the surgeries, and this is where viewers want to let you know that these are the surgery images. So if you're squeamish or you're eating breakfast, you might want to close your eyes for a little bit. We'll tell you when they're off the screen. Okay, here we go. So wow, this is wild. What does this picture show?
Yeah, so this is the culmination of everything Manuel has been through. But, you know, just to get back to where he started, he had an aortic root aneurysm that was intervened on. And the idea behind early intervention is to prevent the most dreaded complication, which is an aortic dissection. And 2 months after his root operation, he had the unthinkable. He had an aortic dissection. And
What did that feel like when you had an aortic dissection?
Just like searing pain. It started from the middle of my back, then it went to my chest and migrated down to my abdomen.
What were you doing when that happened?
I was working. But I wasn't lifting anything heavy. I was just walking around. Then all of a sudden, just you feel this pain, and you're like, "What is happening? What is?"
That's not normal.
Did you collapse? What did the people around you do?
Nothing. Well, I didn't do anything. I just kept walking around, like trying to figure out what was wrong with it. I called my wife, like, "This is happening. What should I do?"
You called Cynthia again? That poor woman. So did she say call 911?
Actually, drove to our house, and she drove me to the ER.
Oh my goodness. What does that feel like as doctors hearing that?
it's scary. I mean, you know, it really set the stage for everything that was to come. Once the aorta tears in a Loeys-Dietz syndrome patient, then the aorta starts to grow very rapidly, and that's what got us to the last year. Yeah. So unfortunately, the dissection started just beyond where he had his aortic root replaced, all through his arch and his descending aorta, and so we had to reconstruct all those vessels, not at the same time, but as a staged approach.
And that's why he had as many surgeries as he had, because we can't address them all from the same incision or from the same strategy. The picture on the screen is actually, as Dr. Crawford was saying, the final stage of the operation, where we actually went in and replaced the entire abdominal aorta, basically from the lower chest through the arteries that branch into the pelvis.
How long of a portion did you?
So the entire length of his torso.
Like a foot? Like a foot and a half?
Oh, at least.
Yeah. And so off of that area, you have all of the blood supply to your kidneys, to your bowel, to your liver, and a significant portion of the blood flow that kind of works together to form the blood flow to your spine and to provide blood flow to the spinal cord, which allows you to have the nerves that allow your muscles to function in your legs. And so when we do this surgery, there's lots of things that we have to be concerned about, but one of the biggest things is paralysis after an operation like this, and thankfully everything went very well and you came through it just fine.
We were talking, Dr. Hessel was saying before the program, you used to think finals in college was a big deal. Yeah. Now you're describing this surgery that you do and that Dr. Crawford you do. How do you not start to sweat when you know everything is at stake? Dr. Crawford, I'll start with you.
I don't know. I mean, I think that's the importance of training. You get used to being in those high pressure scenarios, and then you just grow accustomed to it. Obviously, it's tough when you meet someone like Manuel, who's young, has a wife and kids, and has a lot of life ahead of him. At least that's the reason why we're doing all this and have been so aggressive. And you know, we just stuck to our instincts and worked together, and have, you know, fortunately got him through all this.
What's it like seeing that picture? Is that the first time you've seen the surgery images yourself?
This is I've seen them before when I was at the hospital.
Right.
Dr. Crawford showed them to me. It was surprising, shocking to see myself, I guess,
would be surreal, I think.
Yeah. Yeah.
Dr. Hessel, how often do you as a vascular surgeon team up with cardiothoracic surgeons on patients for the actual surgeries?
So we do this actually quite often. We have a combined clinic where we go and Dr. Crawford and I or one of my other partners will meet with patients that have these types of pathologies where it really requires a multidisciplinary approach in order to treat the entirety of the syndrome or of the aortic pathology. And so we do these cases quite frequently. I would say usually at least on the order of like once every couple of weeks that we're actually doing a surgery. It kind of depends on the patient's pathology and the type of aneurysm or the type of dissection that they have for what we actually do, whether it's a stent on the inside of the vessel or an open surgery to replace segments. But I think to go back to the question of, like how do you go into this and how do you kind of prepare yourself for it, it's all in the planning. So the day of surgery is kind of the, the stage production of things where you actually like go through it, but we've spent hours and hours planning the entire process to make sure that it can go as smoothly as it can.
Mm-hmm. It's a whole bunch of studying to the lead up. As
studying and looking at particular images and planning it for each individual patient.
The surgery that we've been talking about is the complex redo arch replacement under hypothermic circulatory arrest. Dr. Crawford, how do you explain that to someone without a medical background? What's about to happen to them?
It's complicated, and fortunately, you have to rely on their trust in your, planning and ability. Like Dr. Hessel was saying, and like I just heard last week at a conference, you're rarely as a surgeon evaluated for your plan A, whereas you're more evaluated for your plan B and C. And so with someone like Manuel, we have to have a lot of contingency plans, and that happened right away when I went to do his redo arch replacement. We used a specialized graft that has a stent built on the end of it that we deploy first in his arch under hypothermic circulatory arrest, meaning we've stopped all the blood flow to his body. I selectively flow up the right side of his brain so that his brain is seeing some oxygen and nutrients. But I was not able to pass a wire through the true channel because of the extent of his dissection, and so I had to put a wire through the false channel from below and a true channel from above so that I could make sure I put the stent in the right channel.
So you had to find different routes to get where you needed to go.
Yeah, absolutely.
Dr. Hessel, looking at that picture, what are we seeing in that picture? I know it's both you and if we can put that, you and Dr. Crawford. Do you know what point of the surgery that was taken at, or what's happening there?
So it looks like they're probably sewing in, or we're probably sewing in the proximal anastomosis of the graft. I can't tell exactly from it, but that's the final.
Sewing him back up?
No, like putting the graft in, I can't actually tell what the image is.
This is actually from his arch replacement.
Yeah.
Okay.
And so there we're working on the branch vessels to his brain. So we've done the arch anastomosis or connection, and then we have to reconstruct his innominate artery and left carotid artery. And that treats the whole arch.
Okay, and what's the new aortic arch made of?
Oh yeah, it's a tightly woven polyester material. It's kind of like the sail of a ship.
Oh, interesting.
But
kind of interesting.
But very durable.
Dr. Crawford, when you cool the body down, what temperature are you cooling Manuel's body down to, and how do you cool it?
Yeah, it depends a little bit on the extent of the operation. So Manuel, I cooled down to 18 degrees because he's young and he's going to be more metabolically active, and I wanted to make sure that his brain was not needing any oxygen during that time.
How do you cool him down to that?
So we put him on the heart-lung machine, and then with the heart-lung machine we can control the temperature of blood flow into the body.
Okay.
And so that's how we cool.
And then Dr. Hessel, how do you warm him back up after the surgery?
So during that, you can warm the blood as you perfuse it back into the body via the circuit.
Is there any
slow progression?
That's what I was going to ask you. What would happen if you did it too quickly?
There's not really a mechanism to do that. You can heat it to a little bit too much, but then you would denature the cells. So there's stop measures in place on the machines that perfuse back.
This is fascinating. When you hear us talking about this, the patient was on the table. Does it feel like an out-of-body experience? Like that's you. They did this to.
It does. I mean, I get more. I'm more curious as to what it looks like. Like the whole process. Yeah.
What's the last thing you remember before going under for surgery? This most recent one.
being rolled into the surgery. Well, the anesthesiologist just tells you, oh, start counting from 10. I just got to 7 and I was out.
Lights out.
Yeah.
And then how long after the surgery does Manuel wake up?
Well, we like to get an early neurologic assessment, which means we want to know with the first operation, the arch operation, that his brain's okay, that he's following commands and moving his extremities. And then certainly with the last operation that Dr. Hessel and I did, we want to know that he's moving his legs afterwards. So he still has the breathing tube in, but we wake him up pretty early to make sure he can move everything.
That was my question for Dr. Hessel. When you talk about paralysis being a possible risk, one, how big of a risk is it? And two, at what point, is there any point during the surgery where you know that, okay, he's in the clear as far as that goes, or do you have to wait till he wakes up to know?
So we do a lot of things both at the beginning of the surgery and during the surgery to monitor. So we actually have neuromonitoring devices that can help us to know if there's any issues during the operation. One of the things that we actually did during this one, so we can place a drain ahead of time to help the spinal cord kind of like decompress and not be swelling too much in its space. But one of the things that we do during the surgery, and in your particular case, is that we knew that we were going to replace your entire aorta, not just in the abdomen, but also up in the chest. And that was going to take away a lot of the direct blood flow to the spine. And so one of the bypasses that we did that was on that picture is that we actually took a bypass to the arteries that go to your spine to try to help perfuse that. During the neuromonitoring, we can identify if there's a problem. And when we're in the operating room, sometimes we can do bypasses and things like that, or we can push the blood pressure up, or we can drain more aggressively to try to mitigate any of the side effects. But it's a 5 to 10% risk, especially when we're doing open surgery, of developing paralysis after surgery. So we were very happy that you had the result that you did.
Walked right in, looking good.
Thank you.
You're doing great. We already have some questions coming in and some comments from our viewers. If you have anything that you'd like us to read out loud on the program, you can send that to us right now on YouTube or Facebook or the All Things Heart email. Those links are right there on your screen. Manuel, what did recovery look like?
It can be slow. Slow. It can be slow, painful, especially hard because you're not feeling like yourself. The first month is, I would say, the more hardest because you're weak and everything hurts, but after that it just gets easier.
You also have 2 little kids at home, 2 little boys that are very active, climbing all over you.
Well,
what's that like when you're recovering from such a major surgery?
Thankfully my wife just kept them away.
Good old Cynthia, there she is again. She's a champion.
She kept on top of it. She would like give him some space. Yeah, but they knew not to jump on top of me.
Jump on daddy too much. Have you learned anything, and what have you learned about the possible risk of your children having Loeys-Dietz?
It is a genetic condition, so there is a 50% chance of passing it on. So we had our kids tested, so they don't have it, thankfully.
Oh, that's such good news.
Yeah, and however, if we decide to have more kids, there is always that chance that they might have it.
But neither of those beautiful babies had. Yes. Look at those. Oh my gosh, those are cute kids.
Yes.
You just want to squeeze their cheeks. So you did the genetic testing. They're in the clear. This is really incredible. Dr. Crawford, a question for you. How many other Loeys-Dietz patients have you treated? I know, Dr. Hessel, you had said that you're seeing more of them as well.
We see them together in the clinic.
I asked this because Manuel asked when he came in, he said, how common is this? And you had a surprising answer.
Well, it's rare, but I mean, there's certainly a population here in the Midwest. And because they need lifelong treatment and a multidisciplinary approach, Dr. Hessel and I do see a fair number in our multidisciplinary clinic.
You said one of our cardiologists saw 4 last week?
Yeah. So, and also we have more awareness that this is a separate entity now than we used to. I think they all were kind of lumped into one connective tissue population. We realized that there are different diseases with similar
manifestations. The testing has improved.
Yeah.
How many of your patients, if you had to guess, Dr. Hessel, are you operating on because of a genetic condition?
We don't actually know everything about genetics at this point. We're still sussing out a lot of the details of things, and we discover new things every day. We know in many cases that aneurysms develop within families, but we don't know what the primary root of that is in many cases. It's nice when we actually do have a diagnosis so that we can know that we're treating a patient appropriately. It's more difficult in the patients who are on the younger end, who have large aneurysms and have a strong family history, but their genetic testing comes back negative, to know for sure that you're doing the right thing for them in the type of operation that you're operating.
So this is the second show in a row we've done on genetic testing, because yesterday we had a woman and her mom with very rare disease. We talked about the NORD diagnosis that we have with the health system, the medical center, and Children's Mercy that'll help treat people with rare diseases. Genetic testing has come so far. Let's go to some of our community questions that have come in. We have a question from Lisa. Lisa wants to know if all the other surgeries were joint surgeries between Dr. Hessel and Dr. Crawford, and how much time do you wait in between each surgery? Dr. Crawford, let's take you first on that.
Yeah, so one of my partners did the first operation on his aortic root,
Got it.
then I met him after that. And in order to set him up for the arch operation, Dr. Hessel had to first reconstruct blood flow to his left arm and the back of his left brain. So she did a bypass from his carotid to subclavian, and I think I actually scrubbed that with her just because.
I think you can, yeah.
What does it mean when you say you scrubbed it?
That we do the case together.
Together.
Yeah.
So the next question is, who's in charge when it was from Jim. He wants to know about procedure. Which surgeon is in charge when there's two of you in the OR? Dr. Hessel.
It's a joint effort.
But does anyone making the calls, or do you ever say, shh, I got this?
No, we have conversations about things, and we work together to solve problems, and yeah.
How do you agree on what music to play?
Oh, that's a tough one.
I think we usually defer to patients like Manuel and see what they're interested in.
Do you remember making a music request before your surgery?
No, that was probably the last of my worries.
That's true. That's a good point. Becca wants to know, this is for Manuel, when you go in for follow-up scans, how do you not feel anxious?
I usually try to distract myself with work or something else besides, try to think anything besides a follow-up.
Are your little boys old enough to recognize the scar and ask you about it?
They do. I mean, at first they were like, they kept staring at me like, what is that? Does it hurt? Like, feels good. I mean, but.
They're curious.
Yeah, they're curious.
Brad has a question for Dr. Crawford. Brad wants to know, he says, I've seen Dr. Crawford on the show before talking about his own open heart surgery. Did he have the same surgery that was performed on Manuel? And does that mean he has Loeys-Dietz?
Not even close to what Manuel's been through. I would compare what I had, like having a mole removed, compared to what Manuel went through. You know, he was under circulatory arrest for probably 3 times as long, and to have his whole thoracic and abdominal aorta replaced is a much bigger ordeal.
When you say circulatory arrest for our audience, what does that mean?
So interruption of blood flow to the body. We use what's called antegrade cerebral perfusion. So the brain is still seeing some direct blood flow, but the intestines, the kidneys, the legs, they're not getting any blood flow.
How long were you under circulatory arrest?
Oh, I think somewhere around like 15 to 20 minutes, whereas Manuel's was at least an hour.
Wow. And you were a fellow? You were in med school?
I was a fellow.
A fellow when that happened. Jeremy Yenser has a question. He wants to know, is Loeys-Dietz usually found in clusters in a family like that?
Yes. Yeah, so since it's a genetic condition, we often identify it in one person, and then we really strongly recommend genetic testing amongst other family members to make sure that they don't have the same problem, and that if they do, then they're screened appropriately.
Do you know, is it one parent that carries it typically, like the mom or the dad?
Well, like Manuel said, it's an autosomal dominant mutation, meaning if he passes it on, and he either does or does not, so that's why it's a 50% chance, then it's going to be expressed.
And so you didn't pass it on. You're
Yes.
which is, thank
thankfully.
God, again. For today's takeaways, and as Manuel gives his final thoughts for the day, I'd love to show pictures of your little boys again, if we have them. I want to start with you and what you want to say to our viewers who are watching. What do you want them to know? And what do you have to say to Cynthia for encouraging you to go to the doctor?
First of all, thank you for being on top of it. I'll say be more proactive with your health, especially when you have a condition like mine. It can make a really big difference. It can save you.
Don't put it off.
Yeah, exactly.
Dr. Hessel, what would you like our viewers to know?
I think that it's one of the things that's hardest about treating aortic disease is that there's not a lot of signs and symptoms of it. And so you don't know until there is a problem that there is a problem. And so paying attention to family history and knowing that things have, or your prior diagnoses is a good thing, but also just getting regular checkups with a primary care doctor and everything so that if we have an opportunity to catch things, then we try to catch them as early as possible.
Dr. Crawford, what's your today's takeaway for our viewers and for Manuel?
Well, first, Manuel, you're a special guy. Not a lot of people have experienced the loss and tragedy that you have, and since the day I met you, you've had such a good attitude about all this and been so trusting, and it's been a joy to get to know you and your wife and your kids. I think the second thing is, the unique part about our health system now is that because I get to work with people like Dr. Hessel and her team, we really have a true approach to the entire aorta. So Manuel's had his entire aorta replaced now. And that doesn't happen in a lot of centers across the country, but it's something that we can offer to our patients here, and that's pretty special.
This is the place you want to be. Yes. If you have a problem with anything dealing with your heart, your aorta, your vascular system, your vessels. Thank you so much, Dr. Crawford and Dr. Hessel, for taking time out of your day to join us. And Manuel, thanks for joining the conversation and sharing your journey and your family with us. Hope you have a wonderful holiday. Give Cynthia a big hug from us, because she's the reason you're here. And thank you to our viewers for being with us today. If you'd like to watch or share any one of our previous episodes, you can just scan the QR code that's on your screen right now, and it'll take you to links of all of our past episodes. Coming up tomorrow on the Morning Medical Update, the holiday season can bring joy. It can also bring a slew of other things like stress and heavy drinking. Tomorrow we talk about holiday heart and how to get a simple cardiac test to check your heart risk. That's tomorrow at 8 a.m.